Great. Well, I'm going to provide a summary of the panel that we had on new models and approaches to payment. We had a very dynamic panel that started with an overview by Peter Bowling of Virginia Commonwealth University, and then sort of a speed dating style of presentations, 10 minutes each, from a number of very much experts on new models of care, all of which make good use of home health or home-based care. And I think that approach really enabled us to look across those models and see the commonalities and key elements and themes. So the following were among the key themes that I think surfaced during the panel. Most of the models are focusing on the sickest of patients, described at varying breakpoints. For example, the sickest 5% that drive 50% of the spend, the sickest 25% that drive 80% of the spend, and these patients were described as typically being polypharmacy, using many different physicians, and being frequent users of facility-based care, especially hospitalizations and emergency departments. To identify these patients, most use some kind of risk stratification, and often this involves patients with multiple chronic conditions. However, the panel and the workshop participants also strongly emphasized the importance of looking at functional status, assessing IADL and ADL limitations, and identifying patients. And a key element in doing all of this is making sure that we have health information data analytics, information systems, and assessment, all of which are key in this regard. Although there were a variety of care delivery and payment models described, everything from advanced illness management to bundled payment arrangements to accountable care organizations to home-based primary care to hospital at home, all with home health or home-based care components, there were several common elements, and I counted solidly 5. The first is home health's integration with primary care, specifically physicians and APRNs. And I would add to that home health's integration with palliative care and end-of-life care. So overall, home health integration. Second, a focus on care coordination and or care management and care transitions. Third, post-acute care was a major focus in most, but all are working towards achieving proactive, preventive maintenance care. Fourth, nursing and therapy continue to play critical roles in home health care. Some are also making very good use of paraprofessionals, home care aides, and at least one, VNS of New York, is cultivating their role in training and care. Fifth, telehealth and remote monitoring and even phone calls are definitely being used as a means to engage patients and gain scale efficiently in these models. In addition, I'd like to note that person-centered goal setting and integration of family caregivers surfaced as a key theme in terms of making sure that those are key factors in these models. And specifically, the capable model that Sarah Zanton presented really focused on the person's priority goals as opposed to patient goals, person-centered goals. Her presentation was the only one that explicitly called this out, although I'll note that this is a theme that one finds often as a best practice in home health care. Clearly, though, this is a focus and execution for the capable model, which is integrating use of a handyman's modifications with nursing and occupational therapy. Although many of these models are emerging, some of the speakers spoke specifically about impact on outcomes, both in terms of quality and cost. Sutter's Advanced Illness Management Program specifically mentioned that at 90 days post-AIM enrollment, there was a 59% reduction in hospitalizations, 19% reduction in emergency department visits, and 67% reduction in ICU days. This saved $8,290 in total cost per AIM enrollee over 90 days. Data from Optum, which is part of United Health Group, looked at Medicare Advantage plan data. Their Care Plus program, which involves home visits with care management and telehealth, showed a reduction in medical costs at the end of life. Those patients who were home care managed had costs in the last month of life of $4,665 per patient, comparing that with Medicare high-risk patients not in the program costing $17,600 per patient. In addition, various Humana at-home chronic care management and care transitions programs reduced hospitalizations by 42% and rehospitalizations by 39%. So the panel also discussed key policy and payment reforms that might need to be addressed to achieve implementation of these new models. And among those key policy approaches were the following. First, reimbursing appropriately to recognize the importance of functionality or functional status. The ability of home health to support functional needs needs to be reimbursed appropriately. Second, post-acute care bundling as it's being applied in the CMS Bundled Payments for Care Improvement Model 3 was talked about fairly extensively, and it's allowing for more flexibility and creativity in the delivery of care. One key policy change in Model 3 is the waiver of the homebound requirement in the context of that particular model. It's also enabling greater use of nurse practitioners and coordination with primary care. In addition, capitation was an approach that was discussed and highlighted as one that could make sense. And last but not least, payment for value or value-based purchasing was a key approach that was discussed. Another theme discussed was vertical integration. The panelists discussed the impact of integration between providers and payers. And that integration has been important because it's led to alignment of incentives, reaching of a, quote, financial bottom line, and third, improved communication of key information. One question that was raised was how one can achieve those results on a smaller scale, and the panelists recommended not expanding faster than one could deliver or produce results, focusing on best practices, protocols, and tracking of quality and cost metrics. Finally, I think that there was one outstanding question that we did not get to raise, but was raised with me immediately after the panel, and so I wanted to just offer it here. The question that was raised was, to what extent are the new models able to address certain disease-specific areas, such as dementia, in terms of increasing diagnosis rates and reducing preventable hospitalizations? I think that the nature and the format of the panel maybe just didn't allow us to get to disease-specific issues, but it was one question that was raised.
Great, thanks so much for your reflections. That was a good summary. So for those of you who weren't here yesterday, this is available and will be available on the webcast. So I would like to ask Karen Marshall to come up, please. So Karen has been a family caregiver and has established the Kadamba Tree Foundation, and she's going to talk to us from a family caregiver perspective.